I will just give a very brief context about the immuno-oncology scenario in the country. Next slide, please. This is my humble introductions, and I'm at Apollo Hospital as lead for medical and precision oncology, and also a senior consultant at H Reliance Hospital. Please, next, please. So essentially, the immuno-oncology landscape is evolving, and in India, there is expected to increase of 12.8% the cancer incidence, and 1 in 9 individuals likely to develop cancer in their lifetime, which is very alarming, and hence we need innovative and effective solutions. The clinicians, oncologists are having, a dilemma of increasing complex decisions because of multitudes of treatments.
Recording in progress.
And in this scenario, we need to really choose very wisely and precisely our clinics. So the future of cancer immunotherapy hinges on combination therapies, multitudes of treatment options which are available, including checkpoint inhibitors, cellular therapies, etc. Next, please. And in this context, we are trying to make a balance. How can we increase access of these therapies to our country people? And in this context, I would like to give a very brief idea about the Immuno-Oncology Society of India, which is making a lead efforts in this direction. Next, please. So this is February 2018. It is the thought process begins with a group of people. Next, please. And then later on the Nobel resolution is passed. Next, please. And essentially, the aim of this national society was to increase, interdisciplinary interactions among clinicians and scientists, and to ensure uniformity in management in the country, and also encourage basic and clinical research in immuno-oncology, and to assist government and non-governmental agencies in all matters related with immuno-oncology, and also to increase public awareness about immuno-oncology and actively promote continuing education to disseminate the state-of-the-art knowledge on the basic research and treatment of cancer using immunotherapy, and to bring more and more trials in the country so that the access can be increased, and protect, of course, the interest of all the members. Next, please. Next. Next, please. So this is the only registered and legal society in India for immuno-oncology. Next, please. Next, please. So there is 585 members as of now and increasing every time. Next, please. And just to give a brief, overview, that in these 20 years from 2018 till now, there is, we become the partners to the council among the other 20 partners. We are also collaborating with Society for Immunotherapy of Cancer and ISMO and many other Asian societies. We have received many international, members, and they came as speakers and orators for our Congress, inclusive of the Nobel space, Professor James P. Ellison, as well as Professor Hunter. Since our today's guest speakers from Japan, it make even more sense. And we have also had Dr. Walchok and several other speakers. And this time we are having Dr. Kunal Odensi from Chicago Immuno-Oncology Space as our next orator. Our members, inclusive of myself, we become part of the Society of Immunotherapy of Cancer Global Access and Impact Committee member, and also ISMO Investigation in Immunotherapy Track faculty. Next, please. So these are some of the pictures from the last national congresses. We can see the Professor Allison, Professor Honzo, many other distinguished speakers. Next, please. So this is the upcoming Congress. It is happening in 23rd to 25th January in Chennai. And I very warmly welcome our guest speaker as well as everybody who is joining in the space to join hands and experience an academic treat. Next, please. So this is the, our upcoming Congress speakers, orators, Professor Odensi, Professor Kuchru, Professor Shazi Kumar, and Professor Padro, among, many others. Next, please. So this is the, QR code for lifetime membership as well as registration. And very proud to say that almost very, very important member across the globe, our lifetime member of our society. And this is a growing society. We expect much more growth in the coming years. With this, I would hand over it to Mike to the organizers. Thank you. Can we show Dr. Shitara's introductory slide, please? Japan. Here is the, can you display this introduction? Okay, so Dr. Shitara is the director of Department of Gastrointestinal Oncology, National Cancer Center Hospital, East Kashiwaba, Japan. He received his medical degree from Tohaku University School of Medicine in 2002, and he's an active member of ESCO, ESMO, and several other societies. He's working as one of the ESMO faculty member for gastrointestinal tumors, upper digestive tract, for the period of 21 to 25. He's one of the organizing member for these gastric cancer treatment guidelines. His main research entries include development of new anti-cancer agents, optimal chemotherapy regimens for GI cancers, and translational research. His primary investigator or study coordinator was several sponsor-initiated trials and investigator-initiated trials as well. And he's having 200 plus publications and lead articles in many lead journals like Anigem, Lancet, Nature, etc. He was recognized as one of the highest cited researcher by Claveriate in 2022. So with this, I would hand over mic to Dr. Kohei Shitara. Please join. Stage is yours for the proceedings.
Thank you. Very kind introduction. Can you see my slide?
Yes, please.
Great. Thank you for giving me the chance to talk about gastric cancer virtually. So here are my disclosures. So this is a current treatment always, especially according to ESMO guideline for gastric cancers. The doublet fluoropyrimidine and oxaliplatin is preferred backbone chemotherapy always, and we need to test natural biomarker to decide optimal combination, and this biomarker include MSI, HER2, Claudin, FGFR2b in the very near future, as well as a PD-L1 CPS. And these are current benchmark of overall survival after the current standard of care. Median overall survival ranged from 13 to 18 months or 20 months, especially for HER2 positive disease. And looking at the Checkmate 609 biomarker studies, benefit of chemo plus nivo is especially enriched in patients with TMB high, including MSI high, or EBV positive patient. Meanwhile, limited benefit was observed in patients with chromosomal unstable type. And as you know, original TCGA data suggested a high incidence of RTK abnormality, especially in this chromosomal unstable subtype. So these patients are better to be treated by targeted therapy with or without immunotherapy rather than immunotherapy alone. And I believe phase 3 keynote 811 is a quite nice example to show efficacy of immunotherapy and targeted therapy combination. And the benefit was especially enriched in patients with HER2 positive and PD-L1 CPS1 or higher. And this led to regulatory decision to limit its use for this population. And interestingly, there was no enrichment by PD-L1 CPS10 or higher, so CPS1 seemed to be optimal cutoff for this HER2 positive disease. So today, I will mainly focus on TDXT as anti-HER2 ADC for gastric cancer. As everyone knows, antibody drug conjugate or ADC composed of monoclonal antibody linker and a cytotoxic payload. and which can efficiently induce the target specific anti-tumor effect and improve the therapeutic index compared with the naked cytotoxic chemotherapy. And now at least 7 agents for 6 targets are available. TDXD is an anti-HER2 targeted ADC composed of anti-HER2 antibody, cleavable linker, and a DNA topoisomerase inhibitor payload. TDXD has a higher drug-to-antibody ratio, like 8.0, compared with TDM 3.5. And also, TDXD has a cleavable linker, which can induce the bystander phenomenon. In contrast, the previous TDM1 has non-cleavable linkers. In preclinical study, TDXD showed efficacy for cancer cells with HER2 low expression, which is usually resistant to the TDM1 alone. And the payload is released outside the cell membrane after destroying HER2 positive tumor cells, and this is called the bystander phenomenon. And this is especially important for tumor type like gastric cancer with quite heterogeneous HER2 expression. This interesting study using mouse model clearly suggests that the TDXD can be distributed HER2-dependent manner. So once it is incorporated into the HER2 positive cell, but the released cytotoxic payload can attack surrounding HER2 negative tumors. And this DXD was usually distributed nearby HER2 negative cells. So it is not easy to reach out very distant HER2 negative tumors because of the incorporation of HER2 positive and its dependent manner. The efficacy of TDXD for HER2 positive gastric cancer was observed in the first in human study with a response rate of 43%, and the response rate and PFS somehow favored 6.4 mg per kg every 3 weeks compared with 5.4 mg per kg in this gastric study. So 6.4 mg per kg was used in subsequent gastric study, and this dose was higher than that of other types of tumors. So therefore, there is actual debate whether 6.4 is still needed for gastric cancer or not. This is my first responder during dose escalation part. Treatment was discontinued because of persistent thrombocytopenia, but this patient achieved a partial response for primary as well as lymph node metastasis. But eventually, this turned to be complete response because this response was maintained more than 5 years. As shown here, these patients with relatively large liver metastases also achieved a remarkable response to TDXD, and this response was maintained more than a year. So during phase 1 trial and this kind of experience with my patient, I strongly believe this could be the exact treatment for patient. And as everyone knows, Destiny Gastric 01 showed improved response rate and overall survival with TDXD over third-line and later-line chemotherapy in Asian cohort, including Japanese and Korean patients. The confirmed response rate was 43% versus 12%, and median overall survival was improved by more than 4 months. In this study, the activity of TDXD for HER2 low expressing gastric cancer was also exploratory evaluated. Confirmed response rate was 26% in IC2 plus in IC negative population and 10% with IC1 plus population. So these results suggest IC is still an important factor to predict response, but still some efficacy was observed even in HER2 low expressing population. The activity of TDXD was further confirmed in Asian population in this Destiny Gastric 2 study. This is the second-line trial to enroll patients with HER2 positive status after disease progression with trastuzumab and confirmation of HER2 status by fresh biopsies. And response rate and the PFS was almost identical to that of Gastric Summit 1 trial in Asia. So looking at safety results, common adverse events include myelosuppression and GI toxicities. Although 12 patients were judged as interstitial lung disease or ILD or pneumonitis in this DGO1 study, and this is eventually increased up to 16 patients at the updated analysis. The median time to onset was around 3 months, but the range was very wide from 1 month to nearly 2 years. But importantly, most of these events were grade 1 and grade 2. And Gastric Summit 2 also showed a 10% incidence of ILD or pneumonitis in non-Asian population with 2 treatment-related deaths. So management of ILD should be very important. So let me introduce some toxicity management. Myelosuppression and GI toxicity are generally well managed. I would strongly recommend antiemetics, including NK1 inhibitor, corticosteroid, and 5-HT3 inhibitor in all patients. And olanzapine is also useful in some patients based on Japanese randomized study for breast cancer. In clinical trial, we usually check patient status and laboratory tests every weeks during the first cycle, and I still follow same way even in clinical practice if frequent visit is feasible for our patient. For ILD or pneumonitis, it is very important to check chest CT scan to detect early signs of pneumonitis. In the case of suspected ILD or pneumonitis, it is important to discuss with your pulmonologist and radiologist about the possibility or other etiologies such as infection or other causes of pneumonitis. For suspected ILD case, TDXT should be interrupted, and for grade 2 or higher ILD, TDXT should be permanently discontinued. In this guideline, consideration of corticosteroid is described even for grade 1 ILD. And also there is a strong recommendation of steroid use for grade 2 or higher ILD. And this recent data also suggested the re-challenge of TXT after grade 1 ILD, and it seemed to be feasible. But in total, 33, so 1/3 of the patients experienced recurrence of pneumonitis, although most of them were recovered with steroids. So use of re-challenge of TXT after ILD should be carefully decided. The mechanism of ILD or pneumonitis is not clear, but interesting this preclinical study using monkey models suggested target-independent uptake of TXT into alveolar macrophage by Fc bind and the release of the payload as a possible cause of ILD. In January 2021, TDXT was approved by US FDA as a treatment for HER2-positive gastric and GG cancer. And before that, in September 2020, TDXT was also approved in Japan. Furthermore, TDXT was recently approved in China. And interestingly, there is a difference in indication between Japanese and US FDA approval. Japanese indications strictly follow Gastric Summit 01 trial to allow third-line later-line use. So we cannot use TDXT as a second line at this stage. But in US FDA and EMA approval allow TDXT use as a second line with a recommendation of rebiopsy after trastuzumab to confirm HER2 positivity. So this is an important background for additional biomarker analysis. So in this Gastric Summit 01 study, we evaluated a tumor sample and blood sample, including ctDNA. So first, we analyzed the subgroup based on timing of tissue sampling for central assessment for HER2. In 70% of patients, archival tumor tissue before first line was used for central HER2 testing. In contrast, the tumor tissues obtained during or after trastuzumab treatment was used in 30% of patients. And T-DXd showed higher response rate compared with cytotoxic chemotherapy, regardless of this timing of HER2 sampling. But the magnitude of benefit seemed to be a little bit higher in T-DXd, especially if you have a confirmation of HER2 positivity after trastuzumab. So next here you can see the response rate with T-DXd according to biomarker status. These results suggest that the baseline HER2 positive status or high expression in tumor, as well as the ctDNA HER2 amplification is associated with a higher response with T-DXd. In contrast, still response was observed even in HER2 low population or HER2 amplification negative population. And T-DXd activity was observed regardless of presence of RAS mutation or PIK3 mutation. In contrast, relatively low response was observed in patients with other IOTK amplifications such as EGFR, MET, and FGFR. We also compared ctDNA status before and after T-DXd. Although the HER2 amplification was lost in more than 10% of patients on disease progression with trastuzumab. And finally, interestingly, 3 patients showed acquired top 1 mutation on disease progression with trastuzumab T-DXd, and this could be the reason for resistance to the payload. So there's a kind of different resistance mechanism for T-DXd, like this kind of resistance to payload or loss of target on disease progression. So in clinical practice, we have already used T-DXd in more than 100 patients, and which include relatively poor performance status patients compared with clinical trials. And overall efficacy results are still in line with the DESTINY-Gastric other clinical study. And the bone marrow suppression and GI toxicity need to be managed by dose reduction and mix. And the response rate were higher in patients with remaining HER2 positivity, but still, again, response was observed even in patients with loss of HER2 status. And actually, 56% response rate was achieved in patients with remaining HER2 positivity, and the response rate was 30% in patients with HER2 loss after trastuzumab. And interestingly, we observed less tumor burden is associated with the occurrence of ILD. So patients have a relatively small burden, seem to have a high risk or incidence of ILD. So this may be because of the ADC uptake in non-target outside the tumors. And in previous ASCO, we reported the DESTINY-Gastric04 study. Eligible patients should have HER2 positive gastric and GG cancer after disease progression with first-line trastuzumab-based treatment, and the HER2 status was centrally or locally tested using rebiopsy sample after previous trastuzumab, and patients were randomized to T-DXd 6.4 mg per kg compared with the standard of care paclitaxel and ramucirumab in second line. And actually, more than 1,000 patients were screened, and around 40% patients were excluded during tissue screening, and the main reason is loss of HER2 status. And finally, 494 patients were randomized. Regarding patient characteristics, 40% patients were Asian ethnicity, and more than 80% patients had IHC3+, and about 60% patients had liver metastasis, and 16% patients had previously treated by checkpoint inhibitors. And after the protocol treatment, around half of patients received any kind of subsequent anti-cancer treatment, and in total, 25% patients received anti-HER2 ADC after paclitaxel and ramucirumab. This slide showed overall survival, the primary endpoint. Median overall survival was 14.7 months with T-DXd and 11.4 months with RAMPAC, showing 3.3 months improvement with T-DXd. And also, I believe this 14 months should be the longest median survival in second-line global study, and the hazard ratio was 0.70, with significant p-value, and higher 1-year and 2-year survival rate with T-DXd. We also conducted a sensitive analysis to adjust the impact of post-study crossover treatment and censoring anti-cancer treatment in later line, resulting in overall survival hazard ratio 0.64. Furthermore, RPSFT analysis adjusting anti-HER2 ADC after ramp-up showed a hazard ratio of 0.67. So these results are consistent with the primary analysis, which supports survival benefit of T-DXd. Looking at subgroup analysis, OS benefit of T-DXd was generally maintained across most of the subgroup, and the hazard ratio in IC2 plus population was better than that of IC3 plus, although the IC2 plus population was very small. In also, median overall survival in control arm in Asia was longer than that of other regions, but still hazard ratio favored Asian population. This slide shows PFS by investigator assessment. Median PFS was 6.7 months with T-DXd and 5.6 months with ramp-up with hazard ratio of 0.74 with significant p-value. Again, the PFS benefit was also maintained across most of the subgroup. Hazard ratio was almost similar according to HER2 status and geography. The response rate was also higher with T-DXd compared with ramp-up, 44% versus 29%, with significantly longer duration response with T-DXd. Looking at safety, the incidence of serious adverse events were almost similar between two arms. The toxicity profile of T-DXd and ramp-up were consistent with the previous report of each treatment. And importantly, pneumonitis events in T-DXd were observed in 14% patients. Most of them were with grade 1 and grade 2, and there was only one grade 3 and no grade 5 event. In contrast, there was one grade 5 event with ramp-up. And finally, patient-reported outcomes were stable during the study treatment and almost comparable between two arms. And these results support T-DXd as a preferred second-line standard of care for patients with HER2-positive gastric and GG cancer. So what is the next step? In preclinical study, T-DXd showed the activation of dendritic cells and increased MHC1 expression resulted in at least additional or synergistic efficacy with anti-PD-1 therapies. In Destiny Gastric Summit study, we also reported exploratory analysis to assess the impact of previous checkpoint inhibitor exposure. And here, T-DXd showed a higher response rate compared with chemotherapy alone, regardless of such exposure. But the magnitude of benefit seemed to be higher in patients with previous checkpoint inhibitor treatment. And these patients showed increased expression of some chemokine, especially after exposure to anti-PD-1 therapy. In our dataset treated with T-DXd, patient after T-DXd showed increased infiltration of CA cells. And interestingly, patient with highly immunosuppressive tumor and less effective or less responded to T-DXd treatment. So these couple of findings support combination with immune checkpoint inhibitor to modulate the tumor microenvironment and enhance the activity of T-DXd. So based on these kind of rationale, the Destiny Gastric Summit 3 study was conducted to explore the first-line combination approach with T-DXd plus chemotherapy with or without anti-PD-1 therapy. And the recent ASCO GI update demonstrated this arm F incorporating or applying a reduced dose of T-DXd in combination with 5-FU capecitabine with pembrolizumab showed promising activity as well as acceptable safety profile. Looking forward, the Destiny Gastric Summit 5 study as well as the AZ studies are currently ongoing to investigate the T-DXd plus chemotherapy with or without checkpoint inhibitors. And of patient was stratified according to CPS status since current standard of care is determined by CPS and previous engagement Gastric 03 also showed enrichment of benefit of pembrolizumab by CPS while higher population. And also, we have conducted the investigator-initiated phase 2 trial of T-DXd as a neoadjuvant treatment. Initial result of T-DXd monotherapy showed 15% major pathological response rate and 4% with pathological complete response rate. And this response rate was lower than that of our previous expectation. So currently, we are conducting additional cohort to test T-DXd with capecitabine and durvalumab. As shown on the right side, we have also conducted the investigator-initiated trial of T-DXd plus K-POX and nivolumab, especially for HER2-low expressing gastric cancer. As mentioned before, the response rate was 10 to 26% with T-DXd for HER2-low expressing gastric cancer. So it may not be enough to develop it as a monotherapy. So that's why we combined with this multiple combination. So most important recent topic should be how to improve resistance with T-DXd or ADC agent. Various preclinical studies support combination with multiple agents such as anti-EGFR agent, HER2 TKI, VEGF inhibitor, EZH12, and CD47 blocking agent. Your combination with other ADC or bispecific ADC should be interesting, and multiple clinical trials have been conducted to test this kind of new treatment. So lastly, let me briefly introduce some ongoing development with other HER2-targeted agents. This tamibarotene or DV or RC48 is a Chinese ADC with MMAE payload. It showed a single-agent activity with a 25% response rate, and it already received conditional approval in China in later-line setting. Furthermore, combination with multiple chemotherapy or checkpoint inhibitor showed very attractive activity in Chinese study. So currently, phase 3 trial is ongoing, especially for HER2-low expressing gastric cancer in China. ZW25 or zanidatamab is a bispecific agent for HER2, and the binding site is the same with that of trastuzumab as well as pertuzumab. But this single-agent bispecific zanidatamab achieved a more efficient internalization into HER2 or downregulation of HER2 or EGFR signal. And this zanidatamab monotherapy showed a 30% response rate even in later-line setting. Furthermore, chemotherapy combination showed very attractive efficacy. So currently, we are waiting for phase 3 Horizon GA study. And KN026 is a Chinese bispecific agent with a very similar structure with zanidatamab, and it also showed a single-agent activity with a little bit lower incidence of diarrhea compared with zanidatamab. And recently, it is first released that this agent, in combination with second-line later-line chemotherapy, improved the PFS and OS compared with cytotoxic chemotherapy alone. And I believe the result will be presented in upcoming scientific meeting. And HL22 is a monoclonal antibody to different epitope within the same subdomain versus trastuzumab. And interestingly, even within the same domain, these two antibody combination achieved a more downregulation of HER2 signal or EGFR signaling. And the combination with first-line chemotherapy in China also showed a very promising study, and currently phase 3 study is ongoing. So with that, this is a summary of my presentation, and thank you very much for your very kind attention, and I appreciate any question and comment. Thank you. I cannot hear anything. Uh, any question or comment?
So thank you very much, Dr. Shitara. Indeed, it was a great talk and great learning for all of us. And now we'll move on to the panel discussion. And in that, we will discuss about if there are any queries or concerns from the people attending as well. Is that fine? So I request you to please stay with us for that.
Thank you.
So I'm moderating this session of the panel discussion, management of HER2 positive advanced metastatic gastric cancer. And my panelists here are Dr. Kaushik from Mumbai, Dr. Vaibhav Chaudhary from Mumbai, Dr. Preetesh Manot, Dr. Sachin Trivedi, Dr. Jay Mehta, and Dr. Rohit Pai. So majority of them are medical oncologists. Dr. Jay Mehta is pathologist, and Dr. Shitara we have already heard. And I believe this panel will be very interesting. So without much of the time, I'm moving. Also, I would like to introduce, now we have Dr. Advani with us also. So Dr. Advani is a pioneer of medical oncology in the country and kind of mentor to the generations of oncologists. So his presence definitely graced this meeting. So thank you, sir, for coming. And please give your thoughts for this panel discussion also, sir. I would like your presence as well. So Dr. Advani is an expert for this panel, and we will hear from him also. So right now, so first we will discuss about this perioperative talk. Right? First we'll take this perioperative.
After your panel discussion, we'll start with the perioperative too.
Okay, so where's
We can start with your panel.
right? So can we have the second, so next slide? Can we remove the upper bar? So as we know that gastric cancer is the fifth most common cancer diagnosed and in India, and this is the top 5 most frequent cancers as well. Next, please. So I would like to ask from my panelists, what percentage of your gastric cancer cases are diagnosed in advanced gastric cancer? So Dr. Shidara, I will begin from you and then take from my Indian colleagues. Hello, Dr. Shidara.
Can you hear?
Yeah, I want to ask you that what percentage of gastric
Yeah.
diagnosed as advanced gastric cancers?
Well, to be honest, definition of advanced gastric cancer is a little bit unclear, but as you know, in Japan, we have a screening project or a recommendation from government to do endoscopy or control study in people aged more than 40. So as a result, most of our patients in general had early disease like stage 1 disease. So usually this represent more than 60 to nearly 70% of our patients. And 30 to 40% patient had advanced disease in general.
So now I take this question to our Indian colleagues. So Pritesh, what is your take on this?
Contrary to what Dr. Shitara said, our proportion is exactly inverse to what he said. Almost 60% comes as advanced and very few as early stages.
So anybody, you would like to please take this?
Yeah. So I agree with him. I agree with Pratish. 60-40.
So so I think interesting to Japan your advanced cases are really few, while in India we still experience quite a lot of advanced cases. Dr. Advani, sir, what is your take on this? Mike, please.
It also depends upon what you call advanced gastric cancer. The only thing at only time I'll call it early cancer is when it is operable upfront. That should be the definition of, and remaining are all advanced cases. And I feel that at least in our situation, it's only 10% which are surgically operable at the time of initial diagnosis. Either clinically or CT PET scan shows that there are nodal metastasis already, or on the laparoscopic examination, we find some deposits in the peritoneum. So that's what I wanted to ask you. That when you say 40%, what is the meaning of that? Is it these are the 40% who are operable upfront?
Dr. Shitara, the question to you.
Yeah, I mean, 60 to 70% patient could be resected by endoscopical or upfront surgery. So this means, I agree, advanced definition is a little bit unclear, but anyway, we have a more earlier disease in your country because of a screening project by government.
Yeah, so I think it is very clear that because of your screening programs, you are diagnosing the gastric cancer very early in majority of the patient, which is not so, at least in our situation.
Right. I think this underscores the importance of screening programs, and we should really move in the direction. So now, my next question, next, please. So the question is that what is the prevalence of HER2 positive gastric cancer in your practice? And again, I will take the same sequence, the Japan experience, and then I will take from India.
So well, in both metastatic and locally advanced population, HER2 positive is ranged 10% to 15%. So very similar to that of global study.
Right. Oh, and Dr. Pai would like to take this.
So what I feel is that maybe there is a epidemiological difference also, because if there are more of distal cancers, you will have less of HER2 positivity. If it is more proximal, more gastroesophageal junction tumors, that will be more. That will be more. So it can be as high as 30%. That is what the literature says. So probably in Japan, I think the distal cancers are also contributing a significant chunk of the patients. I agree that I think it's around 15% in our case series also. But I think the epidemiological data and the site of gastric cancer is also important. And the type is also important. Intestinal type, it is around 30%. Diffuse type is around 5%.
Absolutely. Next slide, please. So, Dr. Mehta, you are the lead pathologist in the country, and you report, day in day out these cases. So, what is your take on this? The HER2 positivity.
So that's correct. So the gastric ones would be about, say, about 50%, but the G junction ones would be about 5 to 10% more. So that's the thing. And as Dr. Rohit correctly pointed out, so the intestinal ones tend to have much higher positivity versus the diffuse or the poorly differentiated ones. So if you have a resection specimen, then that's the area that the pathologist probably needs to focus. If it's a biopsy, then you don't have much of a choice. You're anyway going to run a HER2 on that particular area.
Right. So this is the data from India, the various studies, variable expression, and as our colleagues rightly pointed out, it depends upon the location as well. So next slide, please. So do you see any differences in HER2 expression between gastric and gastroesophageal? Actually, we have discussed this part, and that is true that we see that this difference is there. And the rate of HER2 positive gastric cancer, do you feel this is lower in real world practice compared to the published studies? Kaushik, you can take this, please.
Yes, in our real world practice, actually, it is around 5 to 10%. We usually see, though all the differences cater between the on the site of lesion also, but in my practice, it is less than 10%.
Dr. Advani, what is your take? You have seen.
I think it's around 10%.
10%. Right. Dr. Shidara, your comments on this?
As mentioned before, our experience is 10 to 15%. And I agree, the incidence is higher in GJ tumor rather than distal gastric cancer. And even in Japan, incidence of GJ cancer is gradually increasing.
Next slide, please. So this is intratumor heterogeneity and anatomy of HER2 expression and cancer. And next slide, please. So this is the variation in HER2 status between primary and metastatic samples. So what is the practice? And considering that this expression, next slide, level can change between primary and metastatic sites. How should the sites be selected to acquire tissue for HER2 testing? Are you testing always primary and metastatic? What is your practice, Dr. Shitara?
Well, we need to always consider risk and benefit for patient. And we recognize this kind of inter-patient heterogeneity, but to do biopsy from all sites of metastasis are not realistic. So I usually tend to do endoscopy and do biopsy. But in patient with disease recurrence after surgery, in lymph node, liver metastasis, I usually ask my radiologist to do biopsy. And we also try to do biopsy, especially after disease progression with trastuzumab in any site of enlargement.
And if there is a heterogeneity, how you proceed between if you do, both the sites biopsy and there is a heterogeneity, what is your go-to?
I believe there's no perfect answer for that, but as recommended in MASTRO guideline like ASCO or ESMO, we always ask our endoscopist to do MASTRO biopsy. So in our institution, our standard procedure is to take 9 feces of endoscopic samples to achieve enough tumor sample to do a MASTRO biomarker analysis. But I believe still we have an issue in intratumoral heterogeneity. So we need to have some solution like imaging study in future or something.
Right. I think you're absolutely spot on. Dr. Pai, your take on this?
So I think what is safely possible, I think we should get the biopsy. If there is a metastatic upfront patient, I think endoscopic biopsy is good enough. But I think after surgery, if it is recurred in the liver or something like that, after some time, there is a good treatment-free interval, we should biopsy the liver met or something like that.
So next slide, please. Sir, you want
I
to
think really up till now, in most of the practice, I think it's a single biopsy. How often do we do the multiple node biopsies and all? If node it with supraclavicular, you can do it, but other nodes you don't touch them normally. So normally it's a single biopsy from the endoscopic biopsy, and on that the practice is done. How many samples do you receive from one patient? Doctor?
Yeah.
No, that's
Dr. Mehta is from pathology domain. So we are discussing here that, what kind of biopsy we receive. It is a multi-core or it's a single core biopsy. So please let us know.
So to answer that is that no, we don't typically get some tissue bits and endoscopy biopsies that one gets. So maybe there's a case to kind of communicating that same to our endoscopy colleagues so that they can actually harvest more tissue for us to kind of factor in heterogeneity for HER2 expression in gastric cancers. And to answer Dr. Advani, seldom does we find a biopsy from a metastatic side and a kind of primary side, and I guess that's the kind of practical thing to it.
My take in this is in gastric cancer, especially advanced, immunohistochemistry plays a role. 4 of the markers, PDL1, MMR, HER2, and Claudin 18.2 are all immunohistochemistry. So that is the reason why you require tissue. Because after that, you might consider comprehensive genomic, that is a whole different ballgame. But probably 6 to 8 biopsy course, I think sensitization should be done. Because it's not like lung. You can have a very small tissue and still get adequate information. There is only one eye.
So one also much and pulmonologist because you also need a tissue for biomarker analysis. So I guess the same thing we can do for our endoscopy colleagues here who are going to take the biopsy tissue. More the merrier, but minimum 8 to 9. So
Dr. Shitara, in it's a very interesting discussion going on. So do you suggest in real world practice, in clinical trials, absolutely, these practices are very kind of established. But in real world, do you feel always we should emphasize that there should be at least 9 cores which should be taken?
Well, there's at least one research paper showing more number of biopsy through endoscopy is needed to actually show high concordance between biopsy sample and the surgical specimen. So that's why in ESMO or ASCO guideline recommend minimum 6 or 8 pieces by endoscopic forceps. So again, in our institution, I ask endoscopists to take 9 pieces, and they are so kind to do for all patients.
Great. So now I'll move again to Dr. Mehta. What advice you would like to give the medical oncology colleagues? They are majority here, and you must be facing difficulties when you're listening. So, what is your take on this?
No, just there should be adequate tissue, and from the pathology perspective, the interpretation for HER2 is different from the breast cancer. So there's a time to kind of sensitize pathology colleagues also that they need to work hard because for a biopsy, it's actually a cluster of 5 cells, a cancer cell cluster, which can actually be positive. Excuse me. So that is something that pass on to your colleagues that information. It should kind of sensitize them, but that's the kind of information that is required from these small issues.
Synaptic report kind of, because it is different than breast. So what would you be your advice to pathology colleagues as well as medical oncology colleagues for minimum standards for?
So what I tend to do is myself is when I write my it's whatever I'm seeing. So it makes it clear for me and for the treating physician. And then there is a kind of explanation score to at the bottom. But for all my reports, I'm sorry, since the advent of DXT for breast tumors or any other HER2 tumors, I just write, even if it's completely, I write that this expression percentage of tumor cells. So just communicates much easier. I avoid getting a phone call back from my colleagues.
Absolutely. So I think yes, there should be clarity because at times we are, when we say something, the medical oncology colleagues and pathology colleagues are not talking on the same language or that they are not on the same page. At times our interpretations differ. So I think it make really a lot of sense if there is elaborate explanation so that we can avoid, calling multiple times or misinterpreting. More than that, even if you can call and get clear, that is better.
Also, like tomorrow, if the HER2 expression gastric cancer also gets traction, if it's already documented, it's useful for you to treat them. Yeah. So that's the advantage of writing a proper report. Yeah.
And there is management armamentarium which is extensively changing with the advent of newer molecules, and we have to be really, really sensitive that what we are seeing in the report, because I always say that our pathology colleagues are very, very important to us because we treat what they report. Next, please. So what is a preferred choice of first-line management of HER2 positive gastric cancer? So these are the options: trastuzumab plus chemo, and immuno, and other combinations. So I would maybe Kaushik, you can start and then we can take it forward.
Yeah, ma'am. So from the last discussion, the best point was I think we have to sensitize my GE colleague also to take as much as biopsies possible. That's actually it's lacking actually to get a multiple course. And once we have a HER2 3+ in IHC, the go-to regimen is Trastu in combination with the Folfox or Capox based chemotherapy. Particularly adding immunotherapy, so we have a CPS on a higher score. If irrespective of CPS, no, it's trastuzumab plus chemotherapy for me.
Pritesh, what is your take?
So if the PDL1 is CPS more than 1, ma'am, then Trust2 chemo and immuno. Else, Trust2 plus chemo is fair enough.
So Dr. Shitara, your take on this?
Yeah, same in Japan. Recently, we received approval of Keynote 11. So we use chemotrast with pembrolizumab for HER2 positive and CPS1 high.
Right. So if it is CPS1 or high, then you would choose always this regimen if there is no contraindication. That would be the take.
Exactly.
Right. Dr. Advani, you want to add or hear anything? Any other
No, I
combination?
think
The current
basically we will use trastuzumab and
next.
chemotherapy.
Right. So these are the guidelines, and I think Dr. Shitara has shown in his presentation also very, very clearly that these are the guidelines today, and these are different US guidelines, European guidelines, Japanese guidelines, and kind of there is a lot of overlap. There is some differences also, but largely they say that, depending upon the biomarkers, we decide therapies these days. So essentially, precision medicine is extremely important, as Dr. Pai was just mentioning, that we need to know these markers because now there is a big therapeutic relevance, not only prognostic. Right. So, Dr. Shitara, what is your take? There are slight difference in the different guidelines. Some recommend, any drug in third line, some and even second line. So how you interpret that, and what is your take in real world?
Well, I think most important difference is TDXT second line before testing got to the fourth study. As mentioned before, we can use TDXT only as a third line, later line in Japan, and same should be true in China. But because of the DG4 data, I believe such a recommendation should be similar in the near future. So after that, I believe global standard of care for HER2-positive gastric cancer become very similar.
Right. And what is your, country practice, or, the legality, or the, authorities involved if there is a one very important randomized trials presented, but the local regulatory bodies haven't approved that drug? How is the practice in Japan that, if you're really convinced about the data, you start, using that molecule, or you still wait for the formal approval from the local authorities?
Oh, we need to wait for regulatory approval, because always regulatory approval is almost equal to the indication of reimbursement.
Right, right. So that issue we also faced a couple of times. So, Dr. Advani, I want your take on this. We see some good trials come into picture. Data is really convincing, but the regulatory bodies take a while to give the nod. Especially even if there is international approval, then still the local bodies. So how to move in that space?
Personally, I feel we should go ahead of the FDA approval, because FDA approval takes its own time. We cannot deny the advantage of the treatment to the patient. So I don't, really, there's no binding on us that we should follow the FDA. But we know that now today the immunotherapy has become a standard treatment for gastric cancer. So I would certainly use upfront immunotherapy. Whether the PD-L1 is positive or negative, it doesn't matter. So normally I would not wait for the FDA approval to occur and then use it.
Right. So, we have to make very cognizant and judicious decisions that, how much time it will take a regulatory body to, interpret and then give the formal approvals, and whether our patient in front of us having that amount of time, and similar time, the legality, the medical legal issues, and the reimbursement issues. Those all are practical things which we always juggle in between and take decisions. Next slide, please. So this is the TOGA phase 3 trial, trastuzumab plus chemo versus chemo alone in HER2 positive gastric or GE junction cancer. It's already, next slide, it's already shown. So it improved OS and PFS. And that's how, it has changed the standard, and it established trastuzumab. Next slide, please. Established trastuzumab plus chemotherapy as the standard of care for patients with HER2 positive advanced gastric or GE junction adenocarcinomas. Next, please. So what has been your real world experience with the TOGA regimen for HER2 positive advanced gastric cancer? Dr. Shitara, your take?
Well, sure, we have several years after introduction of TOGA regimen, and as everyone think this is a quite feasible regimen. Surely trastuzumab has some toxicity like infusion-related reaction or cardiac toxicity, but usually well controlled by supportive care.
Right. And is there any limitation of the TOGA trial that affects its real world application for HER2 positive patients? Dr. Pai, you would like to take this?
So, quite frankly, I think it's a reproducible regimen. I don't think that it's a very good trial because we have trastuzumab generic. I think many people will be actually able to take this treatment, and we have reasonably good results. I think all of us might be having certain patients who are even going beyond 1.5 years, sometimes with the maintenance trastuzumab. So I think I don't see any major limitations. Only thing being that we should how to testing is the main thing. That is the only issue.
Right. So next slide, please. What is the current role of PD-L1 testing in guiding treatment decisions for advanced gastric cancer? We were just discussing with Advani sir as well. So Dr. Shitara, your take on this, and then we'll come on our colleague.
Well, regarding the HER2 positive population, based on KEYNOTE 811, even in Japan, we can use pembrolizumab only for patients with CPS 1 or higher. So this is almost like a CDX. So we couldn't use HER2 positive CPS less than 1 population and pembrolizumab. Regarding the HER2 negative population, we can use either nivolumab or pembrolizumab regardless of PD-L1 CPS status by approval, indication, and reimbursement. But surely CPS is one of the important factors. So clinical decision is based on such information, including MSI, PD-L1, as well as other clinical factors to decide use of checkpoint inhibitor for HER2 negative population.
Right. So, Dr. Mehta, I want to ask you about the PD-L1 testing. Many times, how reliably we can really say that, this companion diagnostics or otherwise, because this is now having a direct bearing on decision for the treatments.
So when we say companion diagnostics, that takes care of the analytic part. So the post-analytic part, to be very honest, is subjective. It's not uniform across pathologists. Something which I would feel is one, somebody else may feel negative, and third person may feel even 10. Despite extensive training, there is a little bit of variability. So I don't know that we'll be able to always be 100% kind of in concordance. But I would say that 90% of the times we are in concordance. So,
Sure. So, because it's having a direct effect on treatment decisions, Dr. Pai, would you like to, comment that, you always go very stringently by this, or like how?
So quite frankly, ma'am, I think Nivo has used 28.8, which is not very Nivo trials. I think that is not very accessible. Usually we go for 22C3. And I think we sort of are happy with the performance and we sort of extrapolate the data, whatever we might be using. And again, like there is still demarcation whether it is more than 5, 1 to 4, less than 1. But overall, ma'am, I think 22C3 is what we are comfortable with.
Sure. Sir, I would like to ask you all this question. One, essentially PD-L1 positivity we have to see, or and the essentially companion diagnostics and the other variations, how you interpret. Because now, the guidelines suggest that, if it is one or more, then we should take X regimen, and if not, then Y regimen, and other trial where it is not HER2 positive, irrespective of that it is working. So, how you interpret this data and what is your real world take? Dr. Advani, your take.
As far as the PDL1 is concerned, I think maybe there's some value of doing this. It wasn't 50% positive response. So it just gives you some indication that you have a good chance, so you can use it up. But if it is 1%, 4%, 5%, I don't think there's a medical difference. Even negatively also, they may respond well. So if you look at the data with the PDL1 negative, that means less than 1%, the response rate is around 30%. So there's hardly any difference. Therefore, I feel that therapeutically, it may not have any sort of impact.
So I think it's very, very important. These discussions are really, really very important, very relevant in day-to-day clinical practice, because whatever we interpret and choose are having a bearing on our treatments. And there is enough evidence in many cancers that, with PD-L1 positivity or with even other biomarker positivity, we may not see response with immunotherapy. And contrary, even if it is completely, negative, other immune markers are also not there, what we call as immune cold, then also they respond at times. So there is variation all across. I would say we are yet to find a perfect biomarker. That's what is my take. And that's how the clinical judgment is the most important biomarker. And, as you grow more gray hairs, perhaps your judgment becomes more wise. So that's how. Next one, please. So keynote 811, pembro plus trastuzumab plus chemotherapy. This is the design already presented. Pembrolizumab significantly improved PFS and OS when combined with post-line trastuzumab and chemotherapy at third interim analysis. So next slide please. Are there particular clinical or biomarker characteristics that influenced your decision to use this regimen? I think part of it we already discussed. Next slide, please. Dr. Shitara, can you quickly comment upon this? Any particular clinical or biomarker? Clinical also.
Well, particularly, we don't have any enough biomarker within this specific subgroup like HER2 positive and CPS1 or higher. But as mentioned before, interestingly, within this subset, the CPS10 or higher didn't show any enrichment of benefit. So CPS1 seemed to be exact cutoff level according to this keynote level. Surely, we are not sure whether this kind of subgroup analysis is a true phenomenon or not, because this is only based on one randomized study. But as you know, to do a multiple trial for HER2 positive population in front line is still, very tough work. And we only have a keynote 11 to have this kind of analysis. So I personally respect such subgroup analysis. But in the very near future, we should have a data from zanidatamab combination. This is also a nice opportunity for us to run additional checkpoint inhibitor role and subgroup analysis according to CPS status.
Next, please. So the data from Keynote 811 influenced the first-line treatment decisions. I think this has been already answered that, depending upon the biomarker and other thing people choose. And in your clinical experience, what benefits and challenges have you observed when adding Pembro to trastuzumab and chemotherapy with these patients? So maybe Dr. Shitara, you can answer again this, and I will be.
Well, I think this is a quite a reflection, feasible regimen in terms of toxicity profile. So we only need to care about toxicity by each component, including chemo, trastuzumab, and pembrolizumab. So outside, we don't have any issue. But surely to use multiple monoclonal antibody is somehow expensive, even in Japan, under reimbursement by government. So this is at least one of the challenges.
Dr. Pai, would you like to comment upon this? What benefits and challenges you observe when adding Pembro to trastuzumab?
So I think the survival is much better, and I think there are a few long-term responders. That is what, and I think we have reached around 20 months with the combination. We had reached around 16 months with trastuzumab alone. Probably increased PD-L1 is one of the resistance mechanism to HER2 blockade, because ADCC is important, I think, in gastric cancer. That is something which is important, and I think this is a synergistic combination. And a long-term play too, probably around 20-25% long-term 3-year survival, I think, is also seen in this study. So I think sustained long-term response and probably the depth of response also is better with this regimen. I think the response rate was around 70 plus. That is the thing. So good response, sustained response, and a plateau, probably.
Dr. Advani, your take on this combination, benefits, pitfalls. Next slide. Sir, your comment. So if we are using the the trio with immuno and anti-HER2 and chemo, what benefit in the clinics and what downside?
Well, I must say that I don't have any experience, because when the HER2 comes positive, we feel we have a good target. And then as taught and as learned, the target therapy is always better than. So that's why we use mainly the targeted therapy along with the chemotherapy. So normally I must say I use the immunotherapy without HER2 negative. Then I use the immunotherapy along with it.
Sure. So the side effect profile, is like this: immune-related adverse event increases. So any experience from anybody would like to share? Pritesh, Kaushik, anybody wants to have a comment about this?
The side effect profile seems to be very similar to when we use immunotherapy, and apart from that, there is no any other red flag which we should see or which would indicate us to avoid the usage of combination. Immune-related adverse events are similar as it is seen in other trials. So, yeah.
But the only thing, when we are using trio, then we are adding benefit of immuno, and the similar time we have to take that, there will be higher chances of immune-related adverse event. Of course, you were right in saying that we have attuned ourselves to manage these side effects better in clinics, but Yes, everything is with pinch of salt. So that's it.
Absolutely.
Yeah. Next, please.
But can we discuss about which chemotherapy do you use?
Yeah, absolutely.
That's
Very
very
relevant.
important.
Yes,
It's not just
absolutely.
immunotherapy and all. Which
Absolutely.
chemotherapy do you use?
Dr. Shitara, do you want to take this? Which chemotherapy backbone along with pembrolizumab and anti-HER2?
K-Fox or 4-Fox, but recently I prefer 4-Fox.
Any
In
specific?
keynote interview, 4-Fox is not used, but we can combine with trastuzumab and pembrolizumab with a flexible schedule. So in institution, we can use 4-Fox based pembrolizumab and trastuzumab combination already.
Right. And do you feel that between Capox and Folfox, the tolerance is the
Well, sure, 4-Fox and K-Fox is similar in terms of efficacy and feasibility, but recently, as mentioned before, we also have a more incidence of GJ tumor with dysphagia, and 4-Fox with lower dose of oxaliplatin every 2 weeks rather than high dose of oxaliplatin every 3 weeks is my preference.
sure? So I think anybody wants to take, sir, what is your regimen of choice? And then we'll
Yeah, I think
chemotherapy.
somehow or other I'm not. I feel cisplatin, 5-fluorouracil, and docetaxel is probably better and rather than the oxaliplatinum. I would like to have your opinion, Dr. Sikara.
Well, recently I never used cisplatin because of the more toxicity, but surely there's no clear benefit of oxaliplatin in terms of efficacy or more similarity in terms of efficacy. So I truly respect your opinion to use cisplatin rather than oxaliplatin. In Japan, a triplet regimen like a DCF or DCS didn't show any survival benefit compared with a doublet regimen in previous large randomized study in Japan. So in clinical practice, we never use triplet regimen, including docetaxel. But in perioperative setting, we already use FLOT as a institutional standard.
Right. So I think very interesting discussions towards the end. So the key takeaways are like advanced gastric cancer remains a major global health challenge with late diagnosis common. Real world HER2 positive rates are often lower than in clinical trials due to tumor heterogeneity and variable testing practices. Accurate HER2 testing is critical for selecting patients who may benefit from targeted therapies. And the TOGA trial established trastuzumab with chemo as first-line standard for HER2 positive disease. The Keynote 811 trial showed that adding pembro to trastuzumab and chemo enhances responses and introduces immunotherapy to first-line management. Managing HER2 heterogeneity and optimizing biomarker assessment are essential for improving patient outcomes. And I would say that space is really advancing. So be watchful for this space. Maybe perhaps in next meeting, we will be discussing some more exciting data. So with this, I will end here. Thank you very much. And we'll move on to the next part of it. So I will invite Dr. Jay Mehta for providing concepts regarding the pathological aspects. Yeah. So I'm just removing this. Like this, Yes.
So we need to have the colleagues in there as well. So that I'm going to present that is already discussed in some of the slides. So we know that how gastric tumor is important in the kind of genesis of gastric cancer, but the prevalence and if we discuss it, it's kind of lesser in real world than clinical trials, but importantly, it's junction tumors versus gastric tumors also depends on the subtype. So it's sort of like subtype of the gastric cancer. If it's intestinal type, it's almost 6 times more. Several diffuse type, which is just about at 5% or so. And to this audience, I don't need to emphasize, but the Destiny gastric trials have demonstrated a statistically significant response rates and survival for 2 weeks compared with chemotherapy treated for the HER2-positive advanced gastric and G-junction adenocarcinomas. Almost every society guidelines recommend HER2 testing for advanced gastric cancer, which is again nothing much to kind of talk about here, but this is something that I would like to emphasize. Is heterogeneity, gastric cancer heterogeneity, it's kind of simple. But there's a question about spatial and temporal heterogeneity. One special one, it's that gastric cancer inhibit variations and levels of HER2 expression. And intratumoral heterogeneity is from 5% to 79%. So that's a huge difference. Current genomic alterations such as different receptor tyrosine kinase, there's a kind of mutation also in the tumor that will give resistance to trastuzumab. You might have intra-patient mutation where the tumor does overexpress the static site might do that. The temperature is after trastuzumab therapy, and of course, which kind of offer resistance to the therapy. So, and this is again something which was, but this is interesting. So, a high degree of heterogeneity gastric tumors will be considered a reason for progression for therapy. And even if you homogeneous gastric cancer, which is but those have a longer survival, PFS about 10.8 months and an OS of about 20.3 months. And these tumors have a higher response rate observed at about 85%. And the depth of tumor shrinkage, which was significantly deeper at shrinkage by 49%, versus tumors which were heterogeneously HER2 positive versus the homogeneously one. They had a shorter survival with the median PFS about 6 months compared to the 10.8 months there, and an OS of 14.4 months versus 29.3. So almost half of that. The response rate was also lower at about 58% versus 85% for the homogeneous ones. And the tumor depth of tumor shrinkage reduction was about 40%, which is not very less, but again, the response rates were much higher otherwise. We again saw this slide, and this is a study which had about 108 patients accrued here, which had where they biopsied both the primary and the metastatic sites synchronously. And this was basically to disprove the fact that if you had a positive in the primary side versus negative in the thing, so that it's not always pre-analytics which play a part in it. There's actually biology involved in this. So of the 108 patients, 10 patients, this is about 10 of them out of 108. So about 10% of these patient population had somewhere where the primary site was positive and the metastatic site was completely negative, and vice versa. Some of the primary tumors were completely negative but positive in the metastatic site. So testing HER2 expression only in the primary site may exclude the targeted therapy to a patient who's potentially kind of deprived of it if you don't actually test the metastatic site, or vice versa. But again, we discussed in a real world, this might be a challenge to do it. But if you're thinking very heavily that the patient needs that therapy, one should escalate that. If you get a negative upfront, try to go for some other site and try to obtain a positivity. This is again the GASTR1 study, which demonstrated the dynamic nature of HER2 expression, where initial biopsy was negative, but the repeat biopsy showed it positive. That's because of the tumor heterogeneity. And also the gastrectomy was negative, but the metastatic site showed positivity. So repeat HER2 assessment in primary and metastatic or recurrent sites is really recommended in patients with advanced gastric cancer whose primary tumor was tested to be HER2 negative. And this is again exemplified in these two papers. The one on the left said that about 30% of the cases exhibited loss of HER2 positivity post progression biopsy. In the study on the right, they said 60% had a change in HER2 expression. However, it was a small study of only 10 patients. Nevertheless, the point to understand here is that if you are going to offer a therapy which is after the trastuzumab based therapy, you need to reassess and recheck the HER2 status, because something, if about 1/3 of them have turned out to be negative, there is no point in then offering TDXT to them. Also, the prescribing information for Enhertu says that you need to check if that tumor overexpresses HER2. So it could be a score 3 or a score 2 with in situ hybridization positive. So the bottom line here, and that's literally the bottom line there, the need to procure a biopsy at first line progression is very important. Now, this is again re-emphasizing the same thing, that the retesting the HER2 status is recommended in patients treated with trastuzumab-based therapy due to a frequent loss of HER2 expression post-therapy. So HER2 scoring in gastric cancer, this is more for the pathologist, but as I had mentioned that it's different than the breast cancer where you look for complete membrane positivity, versus that in gastric cancers, it's basically basal or basolateral reaction. The reason for a different kind of algorithm to test is that if you actually do the breast kind of extrapolation to gastric, you will just miss a whole lot of tumors and you will never get a positivity because it's so heterogeneous and it's almost never complete membrane positivity. A little bit of explanation as to why it's lateral, just to kind of understand it, as it's basically gastric cancers are lumen forming and they secrete their things into the lumen, so that luminal aspect is something which will not take up the staining, versus a breast thing which is not really a glandular disease. And because of the heterogeneity, the cutoff for a biopsy specimen is 5 contiguous cells, a cancer cell cluster, which are kind of evaluated, versus a resection specimen, the same cutoff that you use for breast tumor, 10%. But to obviate the problem of heterogeneity, even cluster of 5 cells is considered as positive for gastric cancers. So how do you mitigate this heterogeneity in gastric cancers? We discussed that we probably sensitize our endoscopy team to obtain more tissues, at least 8 to 9 tissue cores, so that that obviates a need for kind of wondering if you missed out something because of the heterogeneity. To reduce the errors, so you don't actually do the biopsy of a necrotic site, but that's something very elementary and no endoscopist is going to do that. And of course, samples are susceptible to pre-analytic variables, so quickly put them in a neutral buffered formalin. That's very something that is well known. Again, this is studies and guidelines which have said that 6 to 8 cores is something which is a standard thing that one should hope to get from these tumors. Again, needs no re-emphasis that the tissues needs to be processed well, so you need to put it snap in formalin, well processed, neutral buffered formalin. Much of this is the pathologist's job, but if it's a hospital-based practice, then the lab actually provides them the formalin. If it's a standalone endoscopy team which is doing it, then the onus is on the pathologist to provide them the fixative. Talking of the different antibodies, just the way we talk of PD-L1 with different antibodies, several antibodies available for HER2, but what necessarily works for breast cancer doesn't actually work necessarily for gastric cancer. Of all the antibodies which have been tested, the 4B5, which is a Ventana antibody, seems to be the most accurate for assessing HER2 for gastric cancers. And the Hercept test, that's the DACO antibody, which works fairly well for breast cancers, works very poorly for gastric cancers. You get a very low amount of positivity. So if you can discuss that with your pathology colleagues, the Ventana antibody is the one that should ideally be used for gastric cancer analysis. So the key takeaways here in my talk is that all of you know every gastric cancer should be tested for HER2 at diagnosis. HER2 testing on fresh biopsy is also needed, not only a diagnosis, because you want to see if the tumor on progression has lost the HER2 expression. So that's very important, because if you have the intent to treat with TDXD, that's something that you need to know. Again, this is kind of repetitive and rhetorical, is that more the merrier, at least 6 to 8 tissue cores will be useful. And gastric HER2 in gastric cancer should be scored based on the specific gastric cancer evaluating criteria, not the ones which exist for breast. So you could pass on that information if your pathology colleague already doesn't know that. on that basis. Thank you so much. If there are any questions, happy to take them.
You see now, Dr. Jain, when you say that HER2 expression is heterogeneous, it means that some cells are positive, some cells are negative. So if you have, say, 2% positive, you will call it positive.
So it's not based on the percentage. If it's a biopsy, you need a cancer cell cluster. So just about 5 cells, 5 contiguous cells, if they show you basolateral or even weak positivity, the scores for 1, 2, and 3. So if you ask me if there are 2 such clusters which could account for 2% of the entire population, yes, they would be positive, sir.
See, basically, but the concept of the treatment is different. Concept of the treatment is that it is going to act on the HER2 positive cells, which means if you have few clusters, rest are the negative, it will act only on those clusters, not on everything else. So how do you really expect a response in this situation?
So that was that. There was one slide upon kind of just homogeneously positive, everything positive versus heterogeneously positive. Of course, the response rates were poor versus the shrinkage was poor. But what I understand from the TDX is that it latches on to even that 2% cells, and the payload then just distributes it across. That's what, they were wondering that.
That is only with the
TDXD, not for trastuzumab. That's correct. Yes.
like most of the time, whatever some data, mature data is there, is with trastuzumab.
True. So that I agree with you that would be the problem here.
Yeah, I think extremely relevant, and that's how TDX is D is really moving fast in the space and kind of showing promise in many diseases. So thank you very much, Dr. Jay Mehta. Now we'll go into the panel discussion, and Dr. Rushabh Kotari will take it. In the interest of time, we will request him to be bit fast. And he is a consultant and co-founder at Department of Medical Oncology at Oncoven Cancer Center, Ahmedabad, and he is the very dear colleague from Tata Memorial. Long time he was with us there. And the panelists to this panel are Dr. Gaurang Modi, Dr. Hitesh Khadwani, Dr. Palak Bhatt, Dr. Rushabh Rawal, Dr. Mehul Patel, Dr. Mitanshu Sharma, Dr. Pushpendra Hirbara, everybody from Ahmedabad. So stage is yours, Rushabh. Right, and afterward, Dr. Viraj is an expert to this panel. Dr. Rishabh, can we unmute from that end?
Is it audible now?
Yeah, this is audible now. Please go on.
Okay. Good evening, everyone. I would be discussing a case of resectable gastric cancer. Mr. Arun Kumar, 58-year-old male, presented with complaints of early satiety, upper abdominal pain, and was eventually investigated for the same. There was no significant past medical history or
Can you make it in slide mode, please?
direction. This
The full slide. The down bar.
I will just see, ma'am. So basically, this patient underwent upper GI and staging CT scan. Is it okay, ma'am?
Yeah, this is perfect. Please go ahead.
So he was found to have 6 centimeter gastric wall thickening, suspicious perigastric and regional lymph node, no distant mets. Clinical staging was T3N2, performance status PS0. So surgeon is not able to join us. So I would uh, skip all the surgical questions, but take the important ones. Any other investigations which you would do before sending this patient for opinion on resectability? Uh, Dr. Mitanshu?
Laparoscopy examination, sir.
Yeah. So
DLAP examination.
diagnostic laparoscopy. Do you do in all your patients?
We should do in all the patients because the sensitivity of CT is not that much for peritoneal disease, sir. So we should do.
Okay. So diagnostic laparoscopy for all resectable patients. If you have to choose some high risk patients, what are that high risk patients? Where yield of diagnostic laparoscopy would be really high. So I would agree that ideally we should do in all patients, especially if it is more than T1B.
Yeah, mainly diffuse histology is one, signature diffuse histology. T4s tend to have more peritoneal seedling. Non-perigastric regional lymphadenopathy, if you have upper para-aortic D2 area lymph node involvement. So although we do recommend for all, but like you rightly said, these are the ones definitely go for DLAP. The other ones, we just take them for peri-op.
Yeah, so we don't have surgeon, but in practical situations, we have seen a lot of them are not undergoing diagnostic laparoscopy. Most of them are getting operated post neoadjuvant treatment. So what is your practice of doing biomarker in resectable patients? Dr. Pushpendra?
PDL1, HER2, MMR by IHC.
Okay, and you have positive, say HER2 positive, will you act on it in a resectable patient?
No. But yes, MMR by IHC is where there is some data which says 5FU based chemotherapy will have some place.
I think this would be Virat's favorite question. If it is MSI high, will you send to surgeon?
No. So we have Nivo Nipiga. So at least what we could do is give IO and then go for operation. We still don't have data of non-surgical management for gastric cancer. But yes, it opens completely options of perioperative immunotherapy if you have MMR deficiency. But even in otherwise now, we had a Matterhorn readout. So, and very soon we'll get FDA approval. So immunotherapy is here to stay with periops strategy.
So for now, I would say that if patient is deficient MMR, at least in that patient, we would push perioperative IO, even if we don't have approval for the same periop IO in other settings. So this patient was resectable gastric cancer. Think, what is your current standard of practice, Dr. Gaurang, for these patients?
So basically, perioperative float. I think the age of the patient is stable. I think patient
58. 58 PS0.
P0. So perioperative float of 4 cycle, and then pre-evaluation for the surgery.
Okay. So that is fine. Any other regimen? We had triplets with anthracyclines prior. Anyone using that in any situation?
So, we clearly showed MAGIC is inferior to FLOT. So, epirubicin is, I think so, 90% of oncologists have moved to FLOT rather than anthracycline. One other option, which I think so we should now consider, I've started considering since last 2 months, is FLOT plus immunotherapy based on Matterhorn. So it has shown not only PCR improvement, there is an event-free survival improvement, as well as OS trending when you do only censored patients. So that will be in guidelines very soon.
So I've reserved that questions for later slides. So we have a radiation oncologist. Any situation in GE junction or gastric cancer where you would consider radiation in any situations?
So in a neoadjuvant setting, in a float era, float is the standard of care. So no role of or no advantage of adding the radiotherapy in a neoadjuvant setting. If patient directly get operated and come after the post-op in a post-op setting and multiple nodes positive D2 resection is not done, in those scenario, in few cases, we like to add the adjuvant RT plus CT. Otherwise, there is no role of radiotherapy.
So situation where there is nothing given in neoadjuvant.
Yes, exactly.
Upfront surgery
Yes.
and D2 is not done.
Yes.
Okay.
So
And
patient has cardiac comorbid condition. In which case,
Mike, sorry.
so if patient have some cardiac comorbid condition and you are not supposed to give 5FU, then what option do you have?
so I think the cardiac issue is more like the 5FU induced cardiospasms are more kind of, it is not related to coronary artery diseases always. It is happening generally to younger patients who don't have cardiac comorbidities. So just because of some cardiac comorbidity or say ejection fraction of 45-50, it is not necessary that we may not give 5FU based treatment altogether. I'm not very sure, but S1 is bit cardio safe compared to 5FU. And we have data from Eastern countries where S1 is given with, I mean, in this setting, in stomach as adjuvant also. So probably S1 is something which I would consider in such situations. And what Dr. Rushabh alluded to, I'm not very sure whether you would give radiation to patients who have, or you will just give adjuvant chemotherapy and stop. We generally do maybe not float Folfox. We don't know whether Folfox or Capox is float would be better than Folfox or Capox in only adjuvant setting. I'm not very sure, but maybe only Capox or Folfox as adjuvant treatment. I'm not sure whether radiation would add anything in that situation.
So we have seen that most of the gastric patient failed locally. So adjuvant CTRT, if they got operated directly without taking any peri-op chemotherapy. So in adjuvant setting, if the D2 resection is not done, multiple nodes are positive, then adding adjuvant RT is beneficial with the chemo.
Okay. Viraj, your opinion on role of radiation?
So what Dr. Rushabh is saying is McDonald's trial, which was the earlier trial where patients had only D1 resections or not even D1. At that time, adding RT was better than not adding RT. But I think so we moved way beyond that era now. I don't see any indication today, especially in gastric cancer. G junction CWT1 makes it tricky because that's also sometimes surgeons so do want cross there, a small tumor CWT1. But barring that, I don't see anywhere where we have used RT in last 5 years.
CWT1 and squamous, small
No, no,
subset, but
squamous, of course.
so I think
I'm
that,
talking about
yeah,
even
I understood.
adeno.
I understood.
So
in
we
adeno,
use only for adeno,
understood.
right?
Understood.
So in real world, sometimes what happens is like in CVT 2 also, that patient has started on the float and after the 1 or 2 cycle of float, patient has underwent a severe hematological toxicity like HB turns to 4, 5. In those scenarios, sometimes they send a patient to us and then we switch to the cross then the float.
Yeah. So that is appropriate, I think. Okay. So D2 lymph node dissection is something which is needed. I wanted that answer from surgeon, but we don't have. Okay. So we also discussed this, that perioperative float is significantly better in terms of DFS and OS versus anthracycline based triplet, ECF or ECX. And more or less everyone would give perioperative float in such patients. Even toxicity profile, in my experience, is better with float compared to anthracycline based triplet. So Again, this shows that float is better in terms of overall survival compared to pre-operative chemoradiotherapy. And so perioperative float is something which we would consider. The new question which we would have now is how to incorporate immunotherapy in this setting. Uh, we have Matterhorn readout. You have almost 10% increment in event-free survival at 2 years. Overall survival is still immature, and there is trend toward benefit based on what hazard ratio is at this point of time. So how would you incorporate with current available data? We'll take everyone's opinion and then eventually take expert opinion from Dr. Viraj. Dr. Mitanshu?
Yes, sir. We would like to add durvalumab as the Matterhorn trial shows promising results.
Anything you would look, all patients, any PDL1 scoring, any CPS, any TPS, any TEP?
TAP score was used in Sir Matterhorn,
but practically we are not using.
we are not.
So will you do anything or give perioperative IO to everyone?
I will suggest to everyone.
Okay. Dr. Pushpendra?
The concordance between TEP and what we are doing CPS is reasonably good, as shown in some studies. The patients which are DMMR, where I would like to strongly push, for the other, I would definitely discuss in open manner that this is the early data showing very encouraging results and we should incorporate.
Dr. Gaurang?
Already started it in my one patient. Definitely the data.
So
is
basically you are
definitely-
convinced with the data.
Yes, yes. Yes.
Any CPS cutoff which you would look at?
So data which is there is irrespective of PDL1. So
Okay.
there is
So for you in your practice, you
No.
won't look at CPS. Dr. Ritesh?
So I agree that definitely the data is encouraging. So I will discuss in all my eligible patients, and I would like to push for those patients those who are MSI high or CPS score positive. Definitely.
So, Dr. Viraj, deficient MMR, everyone is convinced. Most of the situations, people are convinced. So, we would like to have your expert opinion and what we would do if it is CPS negative.
Right. And rightly so. Why people are still skeptical is because historically, if you see, we had three negative trials, so-called. We had a negative trial with Pembro, Keynote 585. We had negative Nevo, that is Attraction 5. Of course, that was not peri-op. It was after the surgery, adjuvant. And then the Dante plot, which was Tecentric. We don't have survival readouts. PCR is better. So until now, we had these readouts for last 3-4 years, and we have never incorporated. So all eyes were on this study that is, PCR is not a good endpoint. We don't want to start using based on PCR. Is it turning into EFS? So this trial did, and Keynote did not. So somebody would ask, right, why one can show, both showed PCR, mind you. So why would this show and not? The Pembro did not. So there were some differences, and mainly differences was in the statistical design. Okay. This is far larger trial that was also 800 plus patients. Mainly they were more diffuse histology there, right? So we know diffuse histology is not somewhere I tend to push. Intestinal subtype, PDL1 doesn't matter. It's a very crude biomarker, especially when we talk about gastric cancer, early gastric cancer. Even in metastatic gastric cancer, although the approval is beyond 5 and 10, we always debate PDL1 more than 1. Also, we start using it. So PDL1 should not be the criteria. But yes, diffuse histology, even no immunotherapy does well. So what this trial does is opens the era that yes, immunotherapy should be incorporated as early as possible, even before the operation, because the tumor is intact, microenvironment is intact, and there is a better antigen presentation. So yes, like Dr. Gaurang said, we have started using it. We've started offering to our patients, and we only need 2 doses, right? So first cycle, third cycle, it's not much a problem. We know how to manage toxicity. So DMMR, definitely yes. But apart from that also, this should be standard of care now.
And so what is also important for me is like 2-year EFS is a good time point. Most of them otherwise would have recurred by then. So I think 2-year EFS is a reasonable time point. If it was
Correct.
6 month or 12 month, we would have been still waiting for a couple
That's
year or
correct.
so. Okay. If anyone wants to add, I think we have covered these slides in our discussion. So this is the EFS benefit, almost 10%. PDL1 status we have discussed, CPS and TAP we have also discussed. PET CR rate is also high, but what is more important for us is 2-year EFS endpoint compared to the PET CR endpoint. And as we can see, at least 2 or 3 colleagues have already started using this regimen. So most of us are convinced of using perioperative IO with float in this situation. If anyone wants to add anything. Safety point also, Dr. Viraj alluded to that now we are used to handle immunotherapy and immunotherapy plus chemotherapy also across various indications. Yeah, so this is the last slide. Nothing more to add. I think we have discussed most of the things. Thank you. Dr. Jyoti ma'am.
Yeah, thank you very much, Rishabh. Very interesting discussions. And yes, new kid in the block. And I think our armamentarium is widened further. And that's gratifying also. Perhaps if we have to work that how majority of our patients are able to afford it. That's will be the real game changer. And then we'll move on to the next session, which is the case-based discussion for advanced gastric cancer, HER2 positive in second line and beyond. And I would invite Dr. Rajesh Patidar, who's a consultant Department of Medical Oncology at Choidram Hospital, Indore, to take this forward. And again, in the interest of time, I want you all to be very, very, very stringently stuck to the time and skip some of the slides and discuss the relevant one. So the panelists here are Dr. Anup Mantri, Dr. Satvik Khaddar, Dr. Pranjal from Indore, and Dr. Hemendra Mishra. So they all are from Indore, and invite everybody for this lively discussion. And Dr. Amit Asati would be, Dr. Vikas Asati would be the expert for this. I think you are mute.
Yeah, so I'm audible now.
Yes, please. Please go ahead, Rajesh.
I will try to finish at time. So, good evening. And we have case here, Mr. Anil Kumar, who is 62-year-old male. He presented with initial complaint with epigastric pain, early satiety, and unintentional weight loss. Next slide, please. So, biopsy was done and it showed poorly differentiated adenocarcinoma. And on imaging, it was having stage 4 cancer with liver metastasis. And on further workup, immunohistochemistry for HER2, it was IHC 3+, and it was metastatic disease, and he had good performance status. So he received first line therapy with chemotherapy with like capecitabine and cisplatin based on TOGA trial, along with trastuzumab. And he received 7-cycle chemotherapy, which showed partial response. But after 10 cycle, he had a progressive disease, and he had developed new hepatic lesion, and there was increase in the primary tumor size. He still retained good performance status, and there is no significant comorbidities. So now my question is with Dr. Anu, would you perform a fresh biopsy or a repeat HER2 testing in this patient?
No, sir.
You will not perform repeat biopsy for HER2 testing in this patient?
No. I
Dr.
think
Satvik?
It was already positive the first line.
Yeah.
So even if we are planning for TDXD or something, I think I would be comfortable with the baseline biopsy.
Dr. Ramjesh?
data has shown that around 30% cases they turn out to be negative after in the repeat biopsy. So if we are planning for TDX, definitely we do that repeat biopsy for HER2 testing.
Okay, Dr. Pranjal.
I would like to go for biopsy, repeat biopsy.
So yes, agreed. If patient has received anti-HER2 therapy in first line, then we have to do repeat biopsy. We'll discuss data. And what factors would influence your decision to re-biopsy, Dr. Asati?
So I think the most important thing is whether someone has received the target therapy. I think the concept remain the same. The same is true for HER2 positive trastuzumab or for that matter rituximab that we used in lymphoma. So if we have used the target therapy for the given target, and then there is a chance that the tumor might have become negative because we have used that therapy. So if someone has received trastuzumab in the first line setting, and if feasible, as we know that every time it might not be feasible due to location of the tumor or sometime even logistic issues. If they are not there, I will be happy to revive.
Okay. So, Jyoti madam, are you there?
Yes, I'm there.
No. So, ma'am, if re-biopsy is not feasible or patient is not giving consent of re-biopsy, can we consider NGS for HER2 or like liquid biopsy?
See, ideally, if we can heal the tissue, that is always better. If that is just not feasible, then we consider alternatives, inclusive of liquid biopsy also. But here, obtaining tissue is a better choice.
Okay. Okay. So we have to do re-biopsy if we are planning for trastuzumab deruxtecan in second line if patient has received trastuzumab. There are data that around 30% of the patient lose HER2 expression if we give trastuzumab in the first line setting. So have you observed HER2 expression, loss of HER2 expression in your practice? Anyone of us? So like we get only 10 to 15% of the patients who are HER2 positive in advanced stomach cancer, and many of them are not affordable for trastuzumab deruxtecan. So maybe most of us are not, we don't get this patient routinely. So most of us don't have much experience ki how many percent will have loss of HER2 expression post trastuzumab. But yes, now if patient is affordable for trastuzumab deruxtecan, we must do rebiopsy. So what challenges have you encountered with HER2 heterogeneity or discordant results, and how have this affected your management decisions? Dr. Satvik.
So yes, if we are planning TDXD and with HER2 negativity, then it becomes a challenge that earlier HER2 positive. And again, if you're doing a biopsy, it could be a heterogeneous sample also. We cannot be sure that it is actually HER2 negative. So that is why if the patient has benefited significantly with the first line HER2 therapy, even with HER2 negative, I would be inclined to give her a TDXD if there are no other options.
Okay, fair enough. So whenever we do HER2 testing, we should have a good amount of tissue. As already discussed that around 8 to 9 core of the biopsy should be there. So we can distinguish HER2 positive versus HER2 negative tumors. Dr. Hemendra, what other biomarkers you test in metastatic gastric cancer?
So beyond HER2, I would like to see PDL1 and Claudine if it is possible, and NTRK, whichever we can target in the subsequent line.
Any difference of opinion, Dr. Asati?
Apart from that, MSI also we can add.
Okay, so MSI, PDL1, and HER2 testing. These are
and Claudine.
Claudine. These are we are routinely testing, and in
Yes.
second lines or beyond, we sometime we can offer even NGS
Yes.
for NTRK and other rarer mutations.
Yes.
So, what are your preferred choice of regimen in second line management of HER2 positive gastric cancer, Dr. Ramjas?
Yes, sir. So if patient has received trastuzumab first line and now progressed, patient is fit in that there are no any comorbidity like ILD or COPD, hepatitis is fit, not a smoker. So we'll definitely go for TDX. If any contradiction for that TDX from lung point of view, we'll consider that ramucirumab plus paclitaxel.
Okay. So now in HER2 positive second line trastuzumab deruxtecan has become one of the standard, and maybe it is superior to any other available therapy. And if we discuss the data from we have two trials. One is Destiny Gastric 02. Here, patients received TDXD. It was a phase 2 study. And if you see the result of this study, the confirmed overall response rate was 41%, and median duration of response was 8.1 months, and median time to treatment was 1.4 months. And if you see the median overall survival, it was 12.1 months, and median PFS was 5.6 months. So the most common adverse events were like nausea, vomiting, and other adverse events of interest were ILD and pneumonitis. And these all side effects what we observed in this trial, they were similar to in whatever side effects we have seen in other trials also of trastuzumab deruxtecan. Another study, which is a phase 3 trial, and in this trial, patient received TDXD versus remorhizumab with paclitaxel in second line setting in HER2 positive metastatic breast cancer, and the primary endpoint of the study was overall survival. And if we see the survival data, the median overall survival was 14.7 months compared to 11.4 months, with absolute survival benefit of 3.3 months. And if we see the subgroup analysis, in almost all subgroup, there was benefit of TDXD. And if we see the median PFS, it was 6.7 months versus 5.6 months with statistically significant p-value. And if we see the overall response rate were also higher in patients who received TDXD. So, Dr. Satvik, what are your thoughts on OS and PFS data from this trial? Are you convinced with the results of this trial?
So with the bad biology of the disease, although the numerically it looks small clinically, but yes, with the paucity of options, I think we should give the patients the best possible treatment we have as of today.
Okay, Dr. Anu, if patient is affordable, do you think any other option other than trastuzumab deruxtecan to be offered in a fit and eligible patient who is HER2 positive?
I think it's a HER2 positive, then TDX is the only option.
Okay. So I think all panelists agreed that if HER2 is positive and patient has issued trastuzumab, then we have best available data of trastuzumab deruxtecan, and we can use it if we can give it to the patient. So tolerability is similar what we see in other clinical trials, and here even the TDXD was given at for 5.4 months, 1 month extra than ramucirumab and paclitaxel, but the side effects were quite similar. Only the side effects of interest were interstitial lung disease and pneumonitis, and I think most of us have used this drug trastuzumab deruxtecan, and we are trained to manage this side effect. We'll skip this. So I think we all know that if we use trastuzumab deruxtecan, then we should monitor special side effect interstitial lung disease. We can do baseline HRCT, and we should educate patient about this interstitial lung disease. If patient develop cough or breathlessness, then they should report it promptly. And as a clinician, we should also investigate it promptly. So, Dr. Vikas, what is your approach if patient loses HER2 expression on retesting? Do you consider off-label HER2 targeted therapy, or you switch to other therapies?
So basically, I will also see that to what extent the HER2 is lost. So something like a breast cancer where 3+ to 2+ low. So even in low, TDXD is working well, at least in breast cancer. I don't know whether we have the similar data in gastric cancer or not. So if it is completely wiped out, it is 0, I may not be using. But if it is 2+ or something like that, then TDXD is still maybe one of the option, because the reason being the other options that we have are not so effective. So it depends on if it is a loss, to what extent it is.
Yes, agreed. If it is 1 plus or 2 plus, and then still I think we can consider trastuzumab deruxtecan in this.
Yes.
So key takeaways from these trials are repeat biomarker assessment, including HER2 status at progression is recommended whenever feasible, as it can directly influence eligibility and choice of second line therapies. This drug has demonstrated superior efficacy compared to standard option in second line HER2 positive gastric cancer. The safety profile of TDXD is generally manageable, but ILD remains an important adverse event and it requires close monitoring and also early intervention. Patient selection, timely HER2 retesting, and individual risk assessment for toxicity is particularly important. And the evolving evidence for this drug supports its consideration as a preferred second line option for eligible patient with persistent HER2 positivity. Thank you.
So thank you very much for a very interesting discussion, very relevant point, which are important in clinics. And from here, we will move on to discuss about the advanced metastatic gastric cancer, HER2 negative, PD-L1 positive. And for this, I will invite Dr. Tushar Patil from Jupiter Hospital, Pune. And the panelists for this session are Dr. Aman Chaudhary, Dr. Ashwin Rajboj, Dr. Jayant, Dr. Nikhil, Dr. Reshma Puranik, all from Pune. Also, yeah, that's it. And again, my request is to please be stringent on time. Do we have Tushar with us? I asked you to be fast, but not as fast that like directly key takeaways. I think you all are on mute.
Are we audible now?
Yeah, certainly.
Yeah, good evening all. Welcome you all from Pune team. Case-based discussion on advanced metastatic gastric cancer, which is HER2 negative and PD-L1 positive. So we'll just have a case. A 58-year-old male who presented with progressive weight loss, early satiety, abdominal discomfort, good performance status, well-controlled hypertension, no history of family history of malignancy. On endoscopy, found to have an ulceroproliferative growth in gastric antrum and adenocarcinoma on histopathology, which is HER2 negative, PD-L1, CPS more than 5. I would like to ask the first question to Ashwin. In the histopathology and the IHC or the molecular, what other information do you want, or what do you want for the treatment to be planned for this patient?
I think HER2 and PD-L1 is more than enough.
Yeah.
Only one, yeah.
I think
Apart-
MSI?
Not routinely. I normally do PD-L1 only.
Okay. Okay. So HER2, PD-L1, MSI, I think 3 markers, or at least HER2 and PD-L1 being the markers to drive the treatment would be essential for this case. The patient underwent a CT scan showing liver metastasis and perigastric regional lymphadenopathy. The PET scan showed widespread metastatic disease, unresectable locally. He did not have much of he had minor local problems like early satiety, but no other major problems like anemia or low hemoglobin. Hemoglobin was around 11, normal and RFTs.
Can you give us? Hi, your slides are not moving and they are stuck on the key takeaways.
Okay, okay. Slides are not moving. Are they moving now?
I think you can make it enable editing and then perhaps it will start.
Here it's moving. वहाँ नहीं change हो रहा. Is it moving now?
No.
Share.
Free share.
We'll reshare in 2 minutes. Okay, now it stopped moving here. Can I?
Sir, can you click on everything?
Engagement. So we'll just continue with the discussion, I think. Metastatic CS stomach, growth in the gastric antrum, presentation as weight loss, early satiety, discomfort. On PET scan found to have liver metastasis extensive. Biopsy is showing grade 2 adenocarcinoma, which is HER2 negative and PDL1 scoring of CPS 5. Would like to find out what way ahead would you, how do you approach this case? Rishma, if you can take this question.
Sir, so this is a metastatic CS stomach, PDL1 positive, good CPS score. So would like, and it is a metastatic disease. So would like to start with chemotherapy. Seeing the overall performance status and fitness of the patient, would want to advise Folfox along with immunotherapy. I would want to prefer nivolumab, considering CPS score of 5. So along with nivolumab every 15 days.
Okay. Okay. Kaman, if you can take up this question, what is your cutoff for PDL1 if at all you have to use immunotherapy, or are you not using the criteria of any cutoff for PDL1 while we are giving chemotherapy?
More than 5 usually for nivolumab. If I want to use pembro, I'll prefer more than 10, sir.
Okay. Is there any case of using immunotherapy alone in such patients without the use of chemotherapy upfront? What is that scenario?
Sir, deficient MMR, we can go for that. And there are no separate trials, but subgroup analysis was done in those trials, which included, PDL1 positive tumors. So in those trials, they found to have a median survival of close to 38 months also. So we can go for single agent pembro in those patients. And in other patients who are proficient MMR, we may also go for single agent pembro if CPS is more than 10, but again, it was not a separate trial. It was a subgroup analysis, and the trial was not powered to study that. So we may use, but we don't have a very strong data for
So
that.
we don't have a very strong data. And what is the, in general, what is the consensus of using chemotherapy backbone, Folfox or Capox? What?
So preferably Folfox.
Okay. Okay. In the same setting, now we are discussing about HER2 negative, but if it's HER2 positive and also PDL1 CPS score positive, what would be your choice of treatment and how would you sequence your regimen?
Then in that case, we can combine both trastuzumab and immunotherapy with chemotherapy.
Correct, correct, correct. As discussed in the previous discussions, I had an interesting case similarly who was found to have HER2 positive 3 years back. He was put on chemotherapy plus trastuzumab then. He was put on trastuzumab and trastuzumab. He progressed after almost 1.5 years. It was a local progression in the only into the stomach. The liver mets had totally disappeared by then, and they were continued to remain under what we say as control. local growth found. Biopsy was again taken, again HER2 positive, and the PDL1 this time done was again negative. So he was subjected to focal radiation, and again the same treatment was continued. After 1 year again, that is 2.5 years from the diagnosis, he again recurred locally. Liver was still controlled. This time again a rebiopsy done. The HER2 was still positive. This time the PDL1 CPS was 5 or 7. So this time we've added immunotherapy to the existing regimen. Liver is still under control. He's only recurring locally. Jyoti, if you have any thoughts, we can approach this case a little differently. Patient CS stomach, liver meds, and completely controlled. Otherwise, only local recurrence in the stomach happening. Earlier PDL1 was negative, HER2 was positive. HER2 positive on subsequent 2 or 3 biopsies, but PDL1 was negative in the initial biopsy. Now it has come out CPS to be 6.
So what was the patient's earlier regimen? Sorry, I was in.
It was Capox plus trastuzumab. We continued with that. Then he was on maintenance trastuzumab and capecitabine, and he continued to be in remission for control for 1.5 years. He relapsed locally. It was a focal around 1 centimeter disease there in the gastric antrum, which was again considered for radiation. And he continued with the same regimen of trastuzumab and capecitabine for another 1 year after that. Again relapsed the same place. Liver was still under control, and this repeat biopsy showed now PDL1 to be positive. The earlier 2 were negative. Around CPS was around 5. So this time he has been put around for a combination regimen of chemotherapy, trastuzumab, as well as the immunotherapeutic regimen.
So I think the same site failure, the rest of the sites are controlled. That shows that there is a tumor heterogeneity, and the other sites are probably more responsive to the anti-HER2 targeted therapy, while this particular site is showing a clonal evolution or something. Cancer cells are smart; they grow under pressure and they acquire virulence and something of different pathway. So I'm completely in sync that here especially, and even if there is a biomarker which is positive, we should combine immunotherapy to give another pathway check, and the triple combination should work because other sites are responsive to anti-HER2, so we should combine that as well. And triple modality, I am very much proponent for combinatorial therapies. I think there is more than one pathway which is acting on these cells, and I generally perceive it like if we only target one, there is more than often the other pathway which get more expressed, and that's how if we are using combinatorial therapies, they work better.
Yeah, here there was a temptation to use the second line agents which were available like TDX or other agents, but because he was relapsing only at one place, and which could be managed initially with the focal radiation, and then the PDL1 CPS came positive in the third biopsy, maybe we gave him a chance of using immunotherapy along with trastuzumab and chemotherapy.
Appropriate. It looks like that there is a different pathway which is with different mechanisms.
Yes. So this the patient in question, molecular status MSI being stable, EBV negative. Yeah, what would we discussed it, chemotherapy alone or PDL1 inhibitor or clinical trial participation. We've discussed the criteria for selection of immunotherapeutic. I think all agree that CPS 5 or more will be category 1, but yes, even if it shows positivity, possibly we'll have a case to use some or the other immunotherapeutic agent. How commonly are you doing the Claudin 18.2 testing, and are we routinely doing it? What is the case when we are doing? Have we done it in the past, or are you intending to do it in any of your patients, Nikhil?
Doing it routinely, but nowadays with the help of NGS, I'm finding. But I've never treated and not yet found any patient with Claudin.
I would like to ask the other centers any experience with this drug or at least the testing part. Other centers and Jyoti?
So I think it is relevant, but it is difficult to do, and as well as therapeutic relevance that way because of availability thing. So I think logistically challenging, but I believe it is an important marker. Dr. Pai, you would.
So is IHC the methodology to do it, or what is the IHC is the methodology to do it?
It's coordinating. So it is an IHC marker.
Yes.
I don't think there is anything on NGS which will tell us about Claudin 18 per se. And I think you do it just for gathering information. That is what I feel, at least as of now.
Correct.
And there is a drug also which is available. Again, right now it is difficult to get, but at some point, everything becomes feasible. So as he rightly pointed out, that we should know what is our incidence, how our patients are different than what world literature says, and it is an important marker done by IHC. So it's that way, I think we should perform it.
Yes, yes. So these are the phase 3 trials of PD-1 inhibitors in gastric and gastroesophageal junction malignancies. As we can see, checkmate 649, which is nivo plus chemotherapy in advanced setting, median OS of 13.8 versus 11.6 months with a hazard ratio of 0.71. This was the largest global study, and it changed the standard of care in CPS 5 or more. Keynote 062, Pembro plus chemo versus chemotherapy, 10.6 versus 11 months, hazard 0.85, non-inferiority trial. The Attraction 4, which is Nivo plus chemo, including Asian patients, advanced GC and GG adenocarcinomas. Again, no OS benefit here. And Keynote 590, Pembro plus chemo versus chemo in CVERT1 and esophageal squamous cell carcinoma, 12.4 versus 9.8 months, hazard ratio being 0.73 in all comers. In CPS 10 or more, the hazard ratio here was 0.57, as rightly pointed out by Aman, that CPS 10 or more probably could be a case for using either combination of chemo plus Pembro or only pembrolizumab. Also, Checkmate 649, this is the phase 3 global randomized trial evaluating the first line nivolumab plus chemotherapy versus only chemo in advanced HER2 negative gastric and G junction malignancy or esophageal adenocarcinomas. The chemotherapy FOLFOX or CAPOX, and the regimens could be Nivo 240 2 weekly or 360 3 weekly. 13.8 months versus 11.6 months. Any key takeaways from this trial that you would like to offer to the patients, or what is the message? Ashwin?
So, especially for patients with PDL1 more than 5, I think there is a strong benefit of adding nivolumab. And another thing, it can be combined with 3 weekly as well as 2 weekly doses. So maybe with Folfox or Capox, it is feasible to use.
So
I
there
think
is the flexibility of using this
flexibility
drug
of
with either 2 weekly
either two of
regimen
the regimens
or a
right.
3 weekly regimen.
3 weekly regimen,
Yes. Any particular side effect profile that you should be aware of, Reshma, or what you're thinking in terms of using all PD-1 inhibitors, particularly nivolumab, maybe?
This combination, so did not really find anything very particular, but one or two odd patients rash and mild derangements of TSH, but very easy to use. Absolutely didn't have any problem using Folfox with nivolumab.
I think thyroid abnormalities are quite common, that is 5, 7, 8%, or maybe even up to 10%. With Pembro, we've seen a lot of cortisol derangements which happen many times, and there are patients who go into hypocortisolism and have developed secondary manifestations, hypotension, hypoglycemia, hyponatremia sometimes. So this is it. But Nivo is otherwise very well tolerated. That's what these side effects like pneumonitis, hepatitis, colitis, I think are very rare. Very rare, hardly 1 in 100, 1 in 200, 0.5 to 1% chances that these patients would develop this. What has been the real world experience in this regimen in advance? We have discussed that. Toxicity also, I think we have discussed. Commonest toxicities. Doublet regimens offer similar or only slightly inferior efficacy compared to triplets. So what is your take, Aman? But do you, in the metastatic setting, do you use doublet or triplet?
So doublet only. So triplet will be very toxic. But if at all I want to use triplet, then I'll stick to very specific population, like very good performance like ECOG pace of 0 or 1.
Yeah, this patient is 0, 1.
Yeah. So, and if the patient has diffuse histology, maybe in that, and if we need to address the symptoms like is in impending obstruction, like if we want to have a very rapid tumor.
So high burden disease, maybe
Yes,
that
very
also
symptomatic.
highly symptomatic patient,
Yes,
then
yes.
possibly rapid relief of symptoms is what you're
If at all
aiming for.
I want to use, I will use modified float rather than DCFs.
Yeah, so I think that's what the doublet means. 11.2 or 11.4 months OS. All the doublets, triplets give us OS is 9.2. So all are comparable. I think there is no real difference in terms of PFS or OS that they offer. And wherever possible, doublet should be used, barring very good performance status patients, highly symptomatic patients, or high tumor burden status where we want a rapid control of the disease. There is just modest gains by adding the third drug and adding the substantial toxicity because of that. Sorry. We already discussed these 2 points. So for the patients with PD-L1 CPS 5 to 10, is immunotherapy always added to chemotherapy, and are these circumstances where you would consider only chemotherapy? Nikhil, if you can take up this question.
So PDL1 positive with CPS score 5 to 10, I prefer usually nivolumab. Not always, but whenever possible, I prefer with nivolumab.
Okay. And for patients who have a CPS of 1 to 4, what is your take with the limited evidence of immunotherapy benefit in this?
So basically, preferably I use immunotherapy always either CPS score more than 5 or more than 10 or MSI. Otherwise, on low score, I usually don't go.
I think the NIVO trial did show that all patients benefited. If we take the intent to treat population regardless of the PD-L1 status also, there was an advantage. NIVO at least, there was an advantage. So if there is low PD-L1 scoring or maybe even negative, there may be a case of using immunotherapy, because we all know that PD-L1 is not a very good marker as a biomarker for outcomes based on immunotherapeutic approaches for these patients. This is the impact of PD-L1 CPS score on immunotherapy efficacy in advanced gastric cancers. As we could see, if the CPS is very high, 10 or more, median OS stands at 17.4 months as compared to 10.8 months in the chemo alone. 1 or more, 10.6 versus 11.1 months. If we see the checkmate trial 649, CPS more than 5, 14.4 versus 11.1 months, which is hazard ratio of 0.71. Lesser CPS score of 1 to 4, 12.5 versus 12.2, again 0.94. So for lower CPS scores, probably no major advantage of using immunotherapeutic trial. In patients with higher CPS of more than 10, is pembro monotherapy a viable option? We've discussed it. I think Aman has already answered this question. But for all fit patients, probably we'll still use a combination of chemotherapy plus immunotherapy. This was the study. Pembro monotherapy improves survival in CPS more than 10. Median OS stands at 17.4 versus 10.8 as compared to chemotherapy alone. And in this setting, pembro plus chemo did not have any significant added benefit. So pembro monotherapy viable. Guidelines support the option in CPS more than 10 in advanced gastric cancer due to its prolonged OS and lower toxicity profile, but combination therapy may be preferred if rapid control is needed. Any other biomarkers that you would think of, Ashwin? I think we discussed that Claudin is one of the biomarkers and MSI is the other marker, which is
This one.
Claudin and
I
MSI.
think Tisley is approved, so we also have TAP score, which
Correct.
though we are not, I don't have any idea whether it is done or not, but it is not done routine. That is one biomarker which can.
So MSI, Claudin, and TAP is the other three other biomarkers which you could use in patients in this population HER2 negative. This is about zolbetuximab anti-seed Claudin 18 antibody, which improved significantly the PFS and OS in these patients who are positive. They should be HER2 negative. The hazard ratio stands at 0.771, and there is a separation of curves right from maybe month 4 and 6, and the separation continues to be there. 24 months OS of 29 versus 17 months. Two trials, Glow and Spotlight, both showing this. We have we've had this question. Do we do it routinely? I think we are not doing it routinely, but as the treatment gets available more and more accessible, possibly there will be a case to do this testing more often. Coming to the last slide, key takeaways. Personalized therapy in advanced gastric cancer is increasingly driven by molecular biomarkers with HER2, PD-L1, CPS, and Claudin 18.2 now guiding the first-line treatment strategies. The checkmate 649 demonstrated that nivolumab plus chemo offers significant survival benefits for patients with PD-L1 CPS more than 5. And this combination has become the standard of care in this biomarker-selected population. Keynote trials, including 062 and 590, clarified the role of pembrolizumab, showing greater efficacy in patients with higher CPS score 10 or more, while highlighting limited benefit in patients with CPS less than 5. And this Claudin biomarker promising identifies patients who are eligible for zolbetuximab-based therapy. And recent trials, Spotlight and Glow, reported meaningful improvements in the PFS and OS for this positive population of patients. Accurate biomarker testing, including HER2, PD-L1, CPS, now Claudin by IHC, is essential for individualized therapy selection and optimizing the treatment outcomes. With this, we come to the end of it. I hand it over to Jyoti for the final concluding remarks.
So thank you very much, Tushar. Indeed, a very interesting discussion, and thank you very much for stuck on time as well. So we are finishing on time in spite of starting a bit late, so that's good. And I think everybody, brought very interesting cases, and definitely it's a mutual learning from each other and with a real world point of view. So it's very fruitful session. And I would like to thank each one of you for this intense discussion and adding knowledge to this room. This data which is emerging, certainly increasing our armamentarium as far as the patient care is concerned. So this is definitely important. Thank you, my side, also for all the coordinations and support.